So I'm basically going to be talking about digital innovation and implementation. I think I need to start this by saying this has been a journey since I've been a clinical lead over many years, and it's a partnership essentially which we've developed with the Institute for Clinical Science and Technology, which is run by Professor Chris Davis, who's actually a cardiothoracic surgeon who changed course of career towards the end of his training and went into digital innovation, particularly with regards to education. So this is a partnership between the NHS and the Institute for Clinical Science and Technology. So basically, what we've done here is we're trying to align policy to patient, and we've created a toolkit to enable that to happen. And this really has several important components behind it. One of them is national clinical guidelines. I'll show you in a second, but you probably all have seen these. They're posted up all over the place. All outpatients, all GPs practices have them. This is the second iteration, and we now address the green agenda. So there's a big focus on trying to move towards DPIs rather than MDIs in the guidelines. We have national educational standards. This is really important because we don't do the bulk of respiratory work. The bulk of respiratory work is done in primary care, and it's not even GPs who do it. It's actually practice nurses. And what's really important here is that we standardize the sort of interventions that those practice nurses or indeed pharmacists have with the patients. And the asthma annual review is really done, and I think there's a lot of variation, certainly in terms of when I talk to the patients about what they've been told at their annual review. It can be quite variable. So essentially, we've created a national Welsh standard, and once the nurses or GPs or whoever it is have signed up and undergone that training, they do a self-assessment form and they get a certificate to say they are, if you like, competent. They've done the National Welsh Standard, and our recommendation therefore is that everyone who's doing this should have undergone that educational standard. We also have quality improvement projects. So ICST has created the QI toolkit for the Royal College of Physicians NACAP audit, and so that's been really, really important. But built into the ICST platform is really simple QI projects. So, for example, if you go and text a whole range of your patients with asthma or COPD and give them information about where they can download the app, that is a QI project, and you will get information back about how effective that is. And that basically can be published as a QI project. There's all sorts of, if you don't make QI simple, it doesn't work, and that's what we tried to do. So it's real world compliant. And lastly, it's the patient self-management apps. Now, there are apps for everything. There's apps to make your coffee. There's apps to buy food. Apps are not of their self what's going to be really important for driving change. What's really important is all of this is linked in together as a complete toolkit and implemented. Okay, so that's the asthma guideline. So you can see there that we've got nice little green footprints when there's a low carbon global warming impact, i.e. DPI or a mist inhaler, and everything that's an MDI gets a red footprint. And I'm sure you'll hear from others, if you haven't already heard, is that 70% of all inhalers prescribed in Wales are metered dose inhalers. And if you look at Sweden, it's 14%. And if you look at the European average, it's 50%. So we are the worst. This has nothing to do with whether patients can or can't use inhalers, and everything to do with prescribing culture. Okay, so it's not just what we're doing in Wales. The NICE guidelines, BTS, everyone says that we should be prescribing dry powder inhalers unless a patient cannot use a metered dose inhaler. unless a patient cannot use a DPI. Okay, so it's routine dry powder inhalers or mist inhalers. Okay, so, and you can see that it's nice and visually attractive, and you've got the QR codes that link you through to information about the green agenda there as well. And that's the COPD one, same sort of principles. I won't go through it in detail. Just to point out one thing is that if you look at the bottom bit, which has got a red box around it, this bit down here, SABAs, short-acting beta-2 agonists, are only recommended during exacerbations. Okay, so the carbon footprint in Wales is equivalent to 60,000 tons of carbon dioxide equivalent released each year, and 2/3 of that is entirely down to salbutamol or Ventolin. Okay, and that's the most ineffective treatment that we have for COPD and asthma. Okay, so we've got to get away from prescribing these inhalers routinely. They just don't work, and they're just bad. So I spend quite a bit of time telling patients that taking a puff on their inhaler just because they're breathless is not going to improve their exercise ability at all. All right, it just doesn't work. So it is culture change here. We need to change culture, and everyone needs to be doing their bit. So I've shown you that. That's the current carbon footprint, and that's the target by 2025. So we want to go from 30% dry powder inhalers or mist inhalers to 80%. Okay, and that's the target. And if everyone does it, we will reach that target. So the apps. So the apps are part of self-management, or part of co-production, I should say. So they're free for patients. They're bilingual. They're very sophisticated. You put in your inhalers, it takes you to videos about how to use them. There are self-management plans built into them. And we address the green agenda with videos directly to patients. There's an awful lot of other information going through about, how do we communicate with patients to get vaccinated? How do we communicate with patients about pollution? All of these things will be done through the apps. So they're going to be absolutely critical. And that's just some other screenshots showing you how they work. We are able to send a questionnaire out to patients every month, just to get information about how well controlled they are. So when we've got the majority of patients on the apps of our respiratory patients in Wales, we'll be able to know how well a population of asthmatics or COPD patients is controlled. No one has that information anywhere else. So basically, here's some headline data. The initial phase of when we produced the apps, we went out to patients and we said, what did you think of them? Do they help you manage your condition? And 70% of patients initially said the NHS Wales respiratory apps said they helped them manage their condition, but they had a lot of information came back with that, so that the apps were then upgraded and improved. Survey went out again, and currently 90% of patients using the apps feel that they help them manage their condition. That's pretty good. It's extremely rare that you get a digital innovation that would be that well received. This is 93% of GPs practices across Wales have users on the app. So this is not a pilot study. This is implemented at a national level. And the other important thing is that the majority of patients, the vast majority, are actually introduced by their healthcare professional, which suggests that the implementation system that we've developed is working. As of about a month ago, we had 18,000 patients, but our target is hundreds of thousands. So we need everyone to be doing their bit in promoting this. It's not going to work if a few consultants or enthusiasts here and there do it. Everyone needs to be doing it, and then we'll get changes. And we do that, we will find major outcome changes in terms of admissions and indeed deaths. We'll be going in the right way in Wales. So this is just a little bit about implementation science. So usually what happens is you get a pilot study, it's a controlled environment, it works very well because it's a controlled environment. You try and spread it, it doesn't work. So what we do is we work nationally through an implementation science framework. We don't do, it's not a pilot study, this is a national implementation. And we identify, as part of the implementation process, we identify this key layer, which is a green layer identified there, called the power layer. And these are very important, influential people, usually in the community, who have influence over GPs and practice nurses and GPs, and they help spread these innovations out, and that's absolutely crucial to implementation. So we also, this is bespoke software developed by ICST called Simpsy, which is a simple implementation science framework. And basically, just so you realize, we want to go from value proposition to value realization. The value proposition is everyone needs to understand why that there needs to be a benefit for everyone to get everyone aligned. So for the patients, clearly you get better controlled disease. For the healthcare professionals, your patients are better managed, they're less likely to come into hospital, and that's a benefit obviously for the healthcare system. So we want to go from value proposition to value realization. And what you'll see there is these 4 phases of implementation. The development phase is where you create the innovation. That might be the app, it might be the guideline. And then installation phase, often it's adapted and made better, improved. And then, as you can see, the graph shows that the implementation component becomes much bigger with each phase of implementation. And we are really going through into phase 3 now, where we're ramping up implementation. We've created all the innovations, we're ramping up implementation, and we're trying to spread it out. That's when we get the big changes. And that is my presentation.